And prossimo relatore, mi piacerebbe introdurlo in italiano, but I will continue in English. It's obviously a very good friend of mine, and actually, let's say like this, he's Italian, lives in France, but works in Switzerland. And he works since more than 20 years in the Schulthess clinic in Zurich, in the Human Performance Lab, and he's the head of. I have the privilege to work with him over the many years, and he's just one of the world-leading researchers in the field of neuromuscular function. So, please, Nicola, come on. Welcome.
Grazie mille. Thank you so much. I want to start by thanking the two societies that have organized this meeting, Nicola, Mario, Boris, and everyone else involved. The topic is a bit challenging, especially for 15 minutes, and it's about what many people call arthrogenic muscle inhibition. You will see that I will not necessarily call it like this. Reloaded, because I want to bring a new vision and a more simplified vision of that for a better clinical implementation. Does it work? It doesn't work. Is it my fault? Okay. That's why it took a while to come up the slide. You probably have seen this this image on the social media. That's the problem. So the problem here, of course, is pretty much 5 months after ACL reconstruction in a professional soccer player, where after 5 months we are at this level. I don't want to comment anymore. I don't want to say what's wrong or what's good. In my opinion, what I still struggle to understand is that we want to bring our athletes back to their pre-injury muscle strength, muscle mass, while we treat muscle mass or muscle atrophy and muscle weakness as causes. But these are actually the consequences of poor muscle activation immediately after the injury and immediately after the surgery. So what I'm trying to say is that the so-called arthrogenic muscle inhibition, or a deficit of activation, which is nothing but the main determinant of contractile activity, allowing to preserve muscle function and muscle mass. The story is quite simple because there are old studies about arthrogenic muscle weakness, arthrogenic muscle atrophy, and arthrogenic muscle inhibition, which basically popped up mainly starting from 2000. And that's classically been a business for physical therapists. So you probably know the seminal studies. You see two of the main studies here, and you see the number of citations. That increased pretty much regularly until 2015, and then there is a huge change due to the fact that some orthopedic surgeons decided to say that is a problem for us too. And I don't know who's wrong, I don't know who's doing well. I don't want to judge, for sure, but I think that these last 5 years and the future 5 years are the best opportunity to bring physical therapists and physicians together around the same table to try to solve the problem being activation deficit or arthrogenic muscle inhibition. What's arthrogenic muscle inhibition? For me, it's a deficit of activation. If you extend your knee as you are seated and try to do a full quad contraction by palpating your patella or your patellar tendon, you should see something like that. Soccer player, left side healthy, full quadriceps contraction, full flexion of the hip on the left side. The right side, operated 20 days before for ACL, no quadriceps contraction, and very weak hip flexion. Sign of arthrogenic muscle inhibition of activation deficit. And that's something probably you have seen very commonly if you are a therapist or if you are a physician. On the left side, the healthy side, we can assume that activation, if we think about percentage of muscle fibers or motor units, if you prefer, contributing to the contraction, let's say 90%, which is something that we consider normal. Below 90, it starts to be a deficit. Right side, based on what we have seen, it's probably at 10%. And I'm very optimistic, which means this lady only mobilized 10% of the muscle fibers on the injured, operated side. And that's a clear activation deficit. Let's clarify one point. So the point I want to mainly clarify, and that's why I don't like to call it arthrogenic muscle inhibition, because that means that it's mainly from the joint. And the typical reasoning is that the problem is in the joint. There is a damage in the joint due to the tear, due to the injury, but also due to the surgery, because the surgery introduces a second damage to the joint. And that damage damages receptors and several other structures that together with the pain, effusion, disrupts the sensory feedback, which is the red cables going up to the spinal cord, which together disrupt the activation, which is the black cables coming down to activate the muscle. Well, this is a quite simplistic view. And if you read all the articles about arthrogenic muscle inhibition, the definition is it's a complicated, ready to repeat, but it's a presynaptic ongoing reflex inhibition, which, if you try to speak with a neurologist and try to say, do you understand what it is? Probably the neurologist will say, not very much. The concept is that there is a sort of reflex that is going on to protect the joint. But when you look into the pathophysiology, there are 3 possible reflexes, and actually, I don't see how these reflexes can go on for months and be always active to induce this deficit. And that's how we have complexified the issue in the last few years, while it has been said also several times yesterday and today, there are other factors that can contribute to what the patient perceives as a deficit in the activation. For example, pain, for sure. For example, disuse. You have to think about an athlete who stops completely from the day of the lesion, the physical activity level, or reduces a lot the physical activity level. That's disuse. If you send an astronaut into space, he has no ACL rupture, but he will have a decline in activation. And also, let me say that the psychological factors play a big role in this deficit of activation. For the reason that we want to protect our joint, we put in place strategies to not activate the quadriceps, but all these factors together, and that's not just arthrogenic, that's why I don't like very much the definition of arthrogenic muscle ongoing reflex inhibition, contribute to sum up and see what you have seen in the right leg of the lady before. Last important point to clarify is that there are stages of activation deficit. It's not just what you have seen in the lady before. Of course, what you have seen in the lady is probably what a physician, either a sport medicine doctor or an orthopedic surgeon sees before surgery or after surgery. But then the therapist sees something different. That's what a therapist sees. That's a therapist doing EMG biofeedback with a patient who's able to contract, not very well. Probably she has a deficit of 50%. But that's what the therapist sees. And then I guarantee you that when you bring back these athletes to the court and they play again, after having had some tests for clearing their return to sport, they still have a deficit of activation, which is probably 15%, and they keep it for almost forever. These are data published, available. We know very well they keep this deficit forever. So there are 3 stages for me, and the 3 stages are the first one, so the one seen but more by the physician is the severe phase, and that's the severe activation deficit. Call it severe EMI, if you like it. And that's typical after the injury, after surgery. Of course, I'm speaking about ACL, but you can extend a bit this reasoning, I think, to many other pathologies, including muscle injuries. In that case, even better not to speak about arthrogenic origin. The second phase, the one of the therapist, is the substantial phase. So there is a deficit of, let's say, 50% that progressively goes away. And the problem of that deficit is that you are masking the effects of physical therapy, because I want you to contract the muscle. You can only contract 50% of the muscle. How can I rehabilitate your muscle? And then the persistent phase is the one that probably lasts forever. That's when we still keep this deficit that remains months, years after an ACL injury/surgery. And we'll clarify that in the next slides. So this is an example of the time course of activation. It's a representative data. So it's a sort of simulation. Of course, there is big variability. What you can see in this graph is that there is a pre-injury level of activation, which is probably what I have right now, 90%, which means I have a deficit of 10%. And then there is a first phase, which is the injury phase. A second phase is the surgery phase, which we have seen yesterday is quite common after ACL injury. And then there is the recovery phase up to here, 6 months after the injury and the surgery. Let's split a little bit. I will mainly refer to phase 1A, 1B for the post-injury, post-surgery, and phase 2 rehab, just to be clear on what we could eventually do with these patients. Pre-injury phase, these are data from healthy soccer players, semi-professional. This is voluntary activation. We test voluntary activation by asking a maximal voluntary contraction of the quad and doing a stimulation of the quad during the contraction. If there is an increase, that is a sign of a deficit. And you see normative data here from a soccer team. All the points on the pre-match are activation levels from semi-professional soccer players. You have almost everyone around 90, 92%, which is okay. You have 4 players below 90. I don't want to speak about prevention, but these players have a deficit of activation. They are playing. And then you see what happens post. Post is a match. They play a match, 90 minutes, and after the match, you see the activation level goes down. That's why I believe that fatigue plays a role. So when you are fatigued, your activation, in this case also of the quadriceps, goes down drastically, and that could also probably contribute to something. I don't want to go on. 1 day, 2 days, 3 days, that's a recovery of activation in a healthy person, right? I mean, non-injured person. And then there is an injury, and here you see very well the decline of the activation with a big deficit of about 70% within 7 days after the injury. And you see the slight recovery at 20, 40 days. So what you see here, it's always the persistent, substantial, and severe with the different gray colors. And now we know that there are risk factors because there have been a series of patients tested after the injury, before the surgery. And the main risk factors turn to be here, as you can see on the slide: pain, effusion, and eventually, okay, the pillow below the knee and other things that if we mitigate those risk factors, probably we end up with less deficit. You also have protective factors, but that's a long story and too long for 15 minutes. Then the second phase is, okay, you get surgery, pretty much close or not close to the injury, depending on the waiting list, depending on a lot of factors. What you see is the deficit here is greater than the one after the injury. And we typically refer to a double trauma, which means here there is a trauma due to the injury and a trauma induced by the surgery. That's why activation is great. And we also know now, it will be published soon, that there are risk factors for that activation deficit, which is mainly having the deficit before surgery gives you more deficit after surgery. Not having done physical therapy before surgery is a risk factor for post-surgery activation deficit. And finally, pain immediately after surgery is a very high risk factor. So if we summarize a bit and we say, okay, now the therapist and the physicians are seated together around the same table and they speak about that. What can they do together? In my opinion, in these phases, 1A, 1B, they have to prevent an excessive decline of activation. There will be a decline. They have to prevent it in 2 ways. That's probably the job more of the physician. The physician can mitigate by mitigating pain and effusion, which are the main risk factors after the injury. And very often, after the injury, there is a long phase without nothing, where we just wait for the consultation. We know that pre-surgery rehab has become, for some surgeons, has become compulsory, which means some surgeons declare today they do not operate until when a patient has no more deficit of activation. Minimizing tissue damage, and if there are orthopedic surgeons, they will kill me in the coffee break, during surgery, but the damage induced by the arthroscopy, by the procedure, maximize the deficit of activation, unfortunately. And the immediate post-surgery pain management has turned to be very effective. What the therapist can do in the same phase, so we are talking about 1 day after the injury, 1 day after surgery, maintaining the neural circuits that are responsible for activation, which are very simple. If we go back to physiology and neurophysiology, that's the story. With local vibration or tense, we preserve spinal circuits. With motor imagery, action observation, whatever you want, we don't load the joint, we don't load the muscle, but we preserve supraspinal activation. If we do exercise on the healthy leg, we maintain some neural activity, and so on, and so on. And then quickly on the second rehab phase, so we are at this point where the main shared goal would be to promote a progressive re-increase of activation. So now activation will increase. Let's maximize this increase. Let's say that if we have done our job in the previous phase, here it will be much simpler. What therapists mainly can do in this phase is to, in my opinion, not change it too much from what they are doing, but implementing the so-called adjuvant therapies, which are, for example, putting some EMG biofeedback from time to time in the exercise they're already doing, using more electrical stimulation and eventually with a functional approach, so during a movement. Blood flow restriction, which has the advantages also to minimize eventually the loading of the joint. Eccentric exercise, and that's a progression, of course, during the time of the rehab. And at the end of the day, going as close as possible to fast activation, because that's what your athletes need at the end of the rehab process, fast activation. Not just full activation, but fast activation of muscles. We have seen yesterday that as well for the back. What the surgeon can do at the same time, I'm pretty much done. They should endorse more risk-taking, and the risk-taking is doing higher intensity contraction in rehab and the possibility to do maximal contraction to assess, to diagnose where we are in terms of deficit during the rehab process and eventually close to RTP. And now we have also other systems, so I will not go into the details, but high-density EMG is a good way also to get into that, to avoiding the stimulation. And last story, and I will basically do the link with the previous talk, fostering teamwork. The teamwork is that, in my opinion, the surgeon is responsible for giving more support to the therapist in this phase, and also for giving, together with the therapist, more autonomy to the patients, which together will probably bring a simplified vision and a better shared responsibility for focusing on activation deficit. And my last take, and I will be done, is just one. If you can leave the room and think about treating the activation deficit as a main cause of muscle weakness, muscle atrophy, and functional limitations after ACL surgery, instead of a consequence of that. Thank you very much.